Hello, everyone, and welcome to another one of EMS World's podcasts. Today, I am joined by two distinguished gentlemen, Ken Simpson and Dr. Brent Myers. Ken is the Executive Vice President of Pafford Medical Services. Ken is an accomplished healthcare executive who has driven positive healthcare outcomes for residents across numerous cities by creating impactful strategies that unify patient and workforce needs with overreaching business objectives. Dr. Brent Myers is the Chief Medical Officer of ESO. In his role, Dr. Myers focuses on clinical informatics and population health, amongst several other things. He's an internationally recognized expert with a unique combination of in-depth analytical skills and a prolific publisher of research with the ability to effectively translate scientific material for the rest of us lay EMS folks to understand. Gentlemen, welcome to the podcast.
Good morning.
Happy to be here.
Excellent. So let's dive right into our topic today. And I wanted to start with Ken maybe. So Ken, what is the decision-making process that you and your team went through in adopting Logis Dispatch that's a product of ESO? What were you trying to solve? What changed? Kind of give us your, what was your mindset going into it and what you achieved?
So we were really looking for a CAD system that gave us a little bit more of a competitive advantage and interaction with our hospital partners. As healthcare has evolved, we've treated patients and become more and more involved in the healthcare community as a whole, and really wanted to kind of be able to have a CAD system that had the technology and the innovation to offer opportunities to reach out to our hospital partners and make their lives and streamline some of their processes. And likewise on our dispatch side as well, we went from a system that had a lot of manual interventions, and these dispatchers and call takers would have to remember tons of processes and protocols. And we wanted a system that we could build those in to increase the automation and make things happen seamlessly. So it really we were looking for something that became more of a system that we can manage exceptions rather than rules with human intervention. And that was what the path we started out on when we found Logis.
Got it. I understand the concept of, CADs are very complex beings, right? As a paramedic, I take for granted that someone tells me where to go, I hit a button, I start to go there, I get there, I hit another button, right? But there's so many things that happen behind the scenes that we should not underestimate the value of a CAD. And so our conversation here, this concept of a dispatch to discharge, which really not necessarily discharge, but hospital or alternate destination experience, right? Or a soup to nuts in more layperson's terms, software, application. Talk to me about how your decision and this product matches that objective.
So we really have been able to take and pull a lot of that data into the CAD system, because Logis makes it extremely easy to integrate into everything from our primary 911 PSAPs to hospital EHRs. We can pull data in from the initial 911 call that gets taken in the primary PSAP and transferred to the secondary PSAP, and that actually gets transferred out to the providers. That's one of the first things that we really heard from our field crews was, hey, we like being able to read all the CAD notes that are coming over and exactly what the dispatchers and the call takers are being told. It helps us be able to with our scene assessment and things like that. And then the same way from the hospital side, their ability to get online and schedule a transfer and all of that information come across. It stops anybody that's been in the business for any amount of time, especially on the non-emergency side, the nurses and discharge planners, they hate being on the phone and answering 20 questions to your call takers. And so Logis gives you the opportunity for them to fill all that out online. They can do PCS forms online, and it's all workflowed out, so they can't actually close the call until they have all the pertinent information included. And then you can even go a next step and integrate into some of the EHRs, depending on what you're looking for. And that's kind of your 911 and your inter-facility side. And as you alluded to a little bit with mobile integrated healthcare, being able to pull outcomes and data into that, and make decisions and take that data and look at your frequent flyers and identify, hey, you know, these patients, they may not be experiencing a 911 emergency all the time, but they have unmet healthcare needs. And how can we meet them in the middle and figure out, rather than sending this ambulance out to see them, and taking up that valuable resource, can we send a community paramedic or something out or transport them to an alternative destination? So those are
Um,
all benefits.
I think of the cat as I was kind of preparing for today. I was thinking about how in detail the systems must be set up to make a CAD system work. And I'm thinking about like connected data, pulling data coming in from source A, which is a telephone, into a system, moving its way through, collecting the appropriate data, getting it out. I don't want to speak for you because that's why you're here. Tell me a little bit, like walk our audience through. You began using the Logis system. How has it helped you with sort of this connected data environment? Walk us through what it's like before and after having access to Logis, from like when the call comes in until the end of the patient encounter.
So I'll kind of start with the before side, and which leads into the first question you asked about why we were looking. Is we realized that there's a tremendous amount of human intervention involved in our call taking and dispatch process on both the 911 and the interfacility side. And every time you've got one human talking to another human, there are opportunities for things to get mixed up and bad data to come out and that sort of thing. And then we really sat in and watched, hey, what does it look like when they're doing the call taking and the dispatching? And again, we realized how many policies and procedures these call takers and dispatchers are having to work through in the midst of taking this 911 call. And we're like, there has to be a better way to do that. And one of the things that, or several of the things that Logis is able to do is, they have a portal that we have been able to give to our hospital providers. And if they need an ambulance, they get on, they log on, and they can program all that information in and request a transport and say, hey, I want this transport at 2 o'clock. And Logis goes and looks at your booking and says automatically and says, hey, we don't have an availability at 2 o'clock, but we have one at 2:30. Would that work for you? And they can accept the transfer. Not only that, but then they can, the discharge planner, the nurse, they can log in and they can see where that ambulance is. As soon as that call gets dispatched, it gives them an accurate ETA, and they can follow the ambulance all the way to being able to pick them up. So it eliminated some of the calling back and forth for the initial call. It eliminated the calling back and forth for, hey, where's my ambulance and what's the ETA? And then, the call takers and dispatchers had an aversion to the negative reaction they might get if the system was busy and the nurse didn't like the ETA they were given. So, they give a longer ETA, and then we would get calls and, from an administrative standpoint, and hey, they told us it was going to take 3 hours, and everybody got worked up and it was only an hour. Now they can actually track the ambulance, and it's removed a lot of that. We have a large health system in Arkansas that we've given it to, and they have a discharge. They have their own dispatch center basically, and they're able to manage 4 or 5 of their hospitals through this portal, and it's worked tremendously well from that standpoint. We've done the same thing on our 911 side. We've been able to interface into a lot of our primary PSAPs and do CAD to CAD connections between Logis and those other CADs, and giving them, those dispatchers and some of those fire chiefs, the ability to see where the ambulances are, see the calls in their area in a HIPAA compliant way, so they can track the ambulances and they can see all the information that's going back and forth. It's helped a lot with the transparency, and it's helped a lot with the back and forth phone calling. And like I said initially, kind of just even from the initial CAD notes from that primary PSAP, when they answered the phone and saw what the chief complaints were going out to our crews, has been beneficial. and then the accuracy of the information to be able to do that from, from turn by turn directions with the GPS. And the back in the day when I was on an ambulance, I joke, the driver's job was on the fire side. The driver's job was always to go out and hit the en route button while everybody else ran to the restroom and did all the things before you went going. And here we do record that timestamp, but we also record the wheels rolling, so we get a lot more accurate data with that.
Got it. Yeah, data is clearly important. I also kind of note as we talk here about the number of stakeholders that are involved, you know, anywhere from the person who picks up the phone, who may or may not be the patient, to the paramedic, to administration, to, your stakeholders, I mean, there's just a whole lot of people, but the data clearly is important to capture and obviously accurate data. Brent, from a clinical standpoint, why is it so important that we have a continuum of care? We know, but data. How does that continuous data impact patient care, impact system availability? Talk to us about the value proposition behind all of this data that Logis is taking in and putting out.
Yeah, great, thanks. I think there's a way to think about this. When we think about risk, which is really what we're trying to mitigate at dispatch, there's two components of that you think about. One of those is what is the consequence if the bad thing happens, and the other is what's the probability that that bad thing is going to occur. And so you put those two things together and you come up with a plan. The problem has been we have not been able to adequately define either of those because we didn't have the ultimate outcome for the patient. So we've approximated it with somebody gave an IM epinephrine shot, for anaphylaxis, and that became a time critical emergency and that kind of thing. So what we have now is a through line that says, what did the first response do? What did EMS do on scene? How was the patient's condition? What were their vital signs? And then ultimately, were they successfully routed to telemedicine? And we now know if that patient then called back within 72 hours. So we can put an entire safety wrap around this and say, with great certainty, there is a very low probability of anything going wrong. And even if it is, it's going to be pretty inconsequential and not be a lifelong morbidity and certainly not a mortality kind of situation. So from that, it allows you to do two really important things. The first of those is very accurately identify when that true time critical emergency occurs. And we're going to argue with data that is somewhere between 8 and 10% of 911 calls where there's literally seconds matter. And in those cases, you do want to send multiple resources if they're available, lights and siren, for that time critical intervention that may literally be the difference between lifelong disability or mortality. But probably more importantly, quite frankly, we also can define those where that is highly unlikely to occur. And we can offer the alternative destinations for those patients, be it nurse advice, be it facilitated telemedicine, urgent care, all of the community paramedicine, mobile integrated health options. And the beauty of that is those things were often considered separate, but in point of fact, they're directly related. If I am assigning every resource on a first come, first served basis, then it's just by the luck of the draw that my ambulance is available for the cardiac arrest. However, if I can purposefully, dynamically do this, then I can preserve my resources to be sure they're available when that time critical emergency comes in.
So yeah, I mean, it sounds it boils back down to the supply and demand curve here, right? Where we have a decrease in supply and an increase in demand, and now add on top of that the complexities of actually sick people, or maybe they're not so sick people. So what you're suggesting here is that the idea of being able to triage how we respond and who responds is key, and we do that because we have access to the data. Is that accurate?
That's right. And the addition to that is the Logis developers are not primarily fire, EMS, or public safety. Their job was to run logistics, and this platform was originally designated to run all of logistics for the city of Copenhagen. Trash pickup, EMS response, bus routes, you name it. It had all of these different capabilities. And so it became obvious that this also fit the public safety mold very well because they had very granular capability. So, for example, if I'm in a community paramedicine program and I need, a proactive blood draw, 2 days from now, we can put that into Logis and it will tell you every responder in that community that has a skill set that allows them to do a blood draw. And then as the day gets closer, you define how far you want that person to travel, what resources are actually okay to take out of service for that blood draw. And that's all in the background when you set this up. So we don't waste a resource to go do a blood draw. We try not to send a PA to do a blood draw if there's a phlebotomist around the corner, right? That kind of thing that maximizes those resources. But probably more importantly than any of that is the dynamic nature of the way Logis works. For when I was a medical director, and I wrote down here to pick on Ken to see if they actually had to feed the horse time when he was on the ambulance, like was that where they left the building?
Ow.
But at
Not
any
even the
rate,
Cadillac version. We're talking horse and buggy. Wow.
right, yeah.
Ouch. Okay.
We don't have that in Logis, by the way. That delay is not built in for that. But at any rate, when I was a medical director, I'm telling my age now, right, is that we would build these static tables, right? And if you had a 1 alpha 1, then it got these things. And if you had a 33 echo 1, it got these things. And these were the fixed times that were allowed around each of those.
Yep.
There was no way to dynamically respond to the status of the system with those. You might move ambulances around, in system status management, but the response time to those incidents never moved because it was just too complex to do. The beauty is Logis can do that. So if at 3 a.m. you call the very low acuity call and there's every ambulance in the system is available, why make that patient wait, right? There's no reason we can't go to that. But as the system gets busier, we can dynamically move that response time. So we're not telling the community, you have to wait an hour every time you have a non-acute emergency. We're going to say we're going to prioritize in real time based on the resources that are available. And as soon as additional resources become available, we will reprioritize that. So that, over time, yes, there may be an occasion where someone has to wait a little bit longer, but it's not this fixed thing in the background that says all low acuities wait 30 minutes or whatever. It's very dynamic. And I think that is the way that you can move this into a community and have the public accept what we're putting forward.
Got it. Ken, anything you want to add there? Besides that you didn't actually ride with a horse and buggy, which I'm just going to make that assumption, but.
No, really, he's spot on. That's one of the big benefits of Logis and the system that that linear system that ESO has been able to create is the ability to go in and triage those patients and automatically build that rubric in so that when those calls come in, the system is doing it behind the scenes. And that's one of the things that as we've rolled Logis out across all of our areas, that I've talked with my account managers and my operations directors about is like, if there is something that is not working or something that's strange, we need to know about that because it's typically not a Logis issue. It's a how we program the Logis issue. And so going back in and taking a look at that and being able to tweak that here and there to get the desired results that we want has been very valuable. And, anytime you open up any sort of trade magazine in fire and EMS world, it seems like everybody's talking about the huge increases in call volumes and things like that they're seeing. And so the ability to have a tool like this to better manage your system and better manage your resources and still meet those public expectations is a huge asset for any EMS or frankly fire leader.
And Josh, if I can just weigh in on that, we get asked all the time to help systems look at, what their call volume is, when the calls go up and down. And unless you're in a resort community or some, kind of odd area, it is the most predictable curve in the world, right? It's somewhere between 9:30 and 10:30 in the morning, this thing starts cranking up and it'll stay that way till about 7 or 8 o'clock at night, start dwindling back down. And then at 3 and 4 in the morning, there's very little demand, generally speaking. What Logis does is it learns your system. And so at 8:30, it's going to start saying, I'm going to be low in resources in an hour if I keep dispatching at the rate that I'm going. So let's start just a 10-minute hold or a 15-minute hold can often get you over the hump. It's not these hours that, you hear about people having to wait. So it's dynamic not only in what is actually happening, but it learns from the history of your community to know an hour from now we're going to be in trouble unless we start making some changes right now.
So when I first became a paramedic, we had many frequent flyers, which I've been rehabilitated, and they're now friendly faces. Can you talk a little bit about how Logis might improve how we treat patients who may call us with some significant frequency?
Yeah, yeah. So in our manuscript, we refer to these as patients with high utilization,
There we go.
and
Okay.
they have different characteristics at different levels of utilization. And I think that was one of the biggest eye-opening pieces of this. So the part everybody remembers from the paper is that 3% of patients create 16% of the EMS volume, right? And that
Yeah.
over 40% of EMS responses are to someone that's called at least one time previously in the past 12 months. So because Logis can do not only address identification, but individual identification within the software, then we're starting to be able to tailor these responses to people that call us more than one time in every 12 months. What is interesting from that, though, is people like to think, well, the acuity just goes down. In point of fact, it doesn't linearly. If you are someone that calls EMS between 2 and 5 times a year, particularly if you have not been in that category before, then that is a marker for the progression of progression of chronic disease into acute exacerbations. So congestive heart failure, diabetes, Parkinson's, all of those things, when that ambulance hits you more than once a year, and that's not been your historical state, all the way up to 6 or 8 times a year. So that group of patients is just set to have a community paramedicine intervention. Can we check the blood glucose? Can we make sure there's a walker? Can we do the medication checks for congestive heart failure? And that's the signal that that patient is progressing in their chronic disease. Conversely, if you're over 12 times a year calling us, then your median time between each call is only 10 days. And those patients are seeking access to health care, not necessarily having progression of chronic disease. Now, of course, there's mixtures in all of these groups, but the preponderance of people in that larger group are having something not related to chronic disease necessarily, but more of an access to healthcare issue. And so those patients, when they are transported, and today they are transported more frequently than anybody else, they are far less likely to be admitted. And their risk of on-scene death in CPR is almost undetectable. There's just, if you're called 12 more times a year and we're low on resources, there is a moral and ethical pathway to say we're going to hold that call for 5 or 10 minutes if we need to, because the risk of CPR on that case is just de minimis, as opposed to the one caller a year, which is about 1%, or the two to five callers a year, which is a little more than that. So you go to those and you mitigate your risk, as Ken was talking about. So the ability to link it through and have person-specific data in the dispatch platform as opposed to address-specific data allows us to be much more patient-centered in this. And I want to be very clear, we are being patient-centered here. We want to give the patient the care that they need, not force someone into the emergency care system that's not the best option for them.
Got it. So that's seemingly and again, as you said, there are situations that might be different, but you're demonstrating a paradox between acuity and volume. There very well may not be a direct correlation between the number of times people calls and the acuity of their event. That's what you're basically saying.
Yeah, and it's not, well, it's certainly not linear. They're in buckets, right? They're in groups.
Got
So
it.
the person that calls one time a year, you need to check on them, right? Because they may be having, but that's only, by the way, that's only 57% of your responses, just to be
Yeah.
clear.
Yeah.
People that call one time a year, it's just a little over half.
Yeah.
And then that group in the middle are the ones that really need, something related to their chronic disease. And then once you get to what we call the patients with ultra high utilization, once a month or more, then that group is yet a different set of risks. So you're right, there's no linear, like if they call 3 times they're this and 5 times they're that,
Yeah.
but there's evidence to suggest as you move to the different levels of frequency, the preponderance of the complaints in each of those groupings is different.
Yeah, and Logis is adjusting based on these buckets as to how it allocates resources.
Yes, and we are working, quite frankly, for a Q3, Q4 release of a very focused evidence-based module that would allow that to come into play as one factor,
Mm-hmm.
right? As we
Sure.
think about prioritization, it's not the only factor, but it's
Yes.
one factor to think about that prioritization.
Got it. So we have about 5 minutes left. Ken, I thought maybe I'd come back to you and have you address our decision makers, our chiefs that are watching or listening, and maybe give me, give all of us kind of your value proposition behind investing in something like Logis in a connected data infrastructure.
So yeah, I think that, for anybody that's looking for a CAD, or even if you're not looking for a CAD, I think the opportunity that Logis presents to harness the amazing amount of data that we have in the healthcare system, in the emergency services space today, to make those data-driven decisions about how you're going to utilize your resources at a time when everybody has budget struggles and staffing struggles and things like that, is of paramount importance. And likewise, the ability to have the transparency and offer the transparency into your stakeholders is also a huge value add. I think that it's something that every leader should take a hard look at for their system. In all honesty, I can't think of a system that wouldn't benefit from it. Like Dr. Myers talks about, their ability to even take the hospital outcome data and harness that into how the system works, how the system moves your resources, prioritizes your calls, and allows you to utilize your resources is important. And the other thing that I've really enjoyed about working with Logis is as we've come up with questions and things like that, if it's not something they currently do, it's something that they'll take a look at and kind of have further conversations with you about and determine whether it's something that they might be able to offer and implement for you. So I think from that standpoint, it's time well spent. It provides you a advantage for your communities, and it's something that every responsible department leader, EMS agency leader really needs to take a hard look at.
So I started that all makes perfect sense, and I think that it kind of bring it back around. I started by saying that I underestimated, and again my small paramedic head here, I underestimated kind of the complexities of a CAD system and where it starts to where it ends, and that continues to grow. I would also be remiss in doing a podcast in 2026 and not talk about AI and artificial intelligence. So Brent, maybe you can take what Ken said, add what I said, and bring us to how is Logis throughout its encounter utilizing AI to the advantage of its client and the advantage of the ultimate patient.
Great. No, and I really appreciate that question. And you're right? We can in 2026 not address this. So a couple of things. When we think about AI within the ESO walls, and Logis obviously being part of that, the first thing that we do is we want to make sure that it's transparent, that people know the data that we're basing this on and what decisions are being made dynamically versus what decisions are being made retrospectively and then informing a model. So for example, we have published and defined, these are the time critical emergencies in the field. These are the time critical emergencies in the ED. Here's the list that we use to do that. From there, we now have it on a static table defined the 450 most common medical priority dispatch codes from the most acute to the least acute based on those coming together. And from there, we have a static model that then informs the day-to-day operations. So we are not in the midst of, call after call after call, calling out to an AI agent to then make a decision and then come back, because we're just not there yet. Now, might we be there next week, next month, next year? Sure. And we'll be transparent if that indeed is ever the case. But we don't want to be, in the midst of that time criticalness and doing that. Now, conversely, there are already in the field, and not with Logis as of yet, but available soon, the ability for an AI agent to grab a call. And so I was at Navigator, and there was a great presentation about a system that put a geofence around working structure fires and accidents on the interstate highway system, because both of those events generate multiple calls for the same thing. And it was overwhelming the system, all the calls for that same structure fire, all the calls for that same accident. And so all the AI agent did is pick up the phone and say, we are responding to an accident at mile marker, whatever. This is what we know. Do you have additional information? If yes, go to a live person. If not, thank you for your call. Same thing for the structure fire. So there are very discrete places where it makes sense today. But to me, the most important thing about all of it is that your local community has a governance board that is stakeholders from the community, public safety, hospitals, wherever it is, and then you decide together what's right for your community as it relates to this. Because there is anything that we said today is not going to apply tomorrow, right? It is going so fast, so we can't lay down a rule or a policy necessarily, but we can have everyone that needs to be involved in decision making looking at the advances as they come. So that's kind of the way we think about it. But the most important piece, again, is that we're transparent and that we're using data that actually comes from the EMS and public safety field, not data from some other part of healthcare to try to force it into the EMS space.
Got it. Ken, any final words?
I really appreciate all the work that the ESO team in general has put into developing and continuing to innovate this project. That's something that we talked about earlier, and as we embarked on, our research was the investment that they make and that they continue to make, and trying to figure out how to make the system work better and how to make it, like with the AI, healthcare is kind of the same way. It continues to evolve, and we have to continue to work and to change. And ESO has been with us lockstep as we've worked to try to do that, everything from day-to-day 911 calls to rural health transformation programs and MIH and all that. And so I think that it's, like I said in your last question, it's anybody that's looking to take their agency to the next level, it's something they should give serious consideration to.
Well, I think we spent some valuable time today understanding the complexities of a CAD system, the advantages of a connected CAD system, the abilities and capabilities of the Logis system, and talking about where we came from, where we are now, and where we're headed when it comes to computer-aided dispatch. I wanted to thank you both for your time. I appreciate it. I know your schedules are busy, so thank you for making time to spend this half-hour podcast with us at EMS World. And we look forward to speaking to you guys both again very soon.
Thank you, Josh.
Yeah, thanks for having me.